perinatal mood disorders. Ms. Davis has been providing counseling and training on perinatal mood disorders for almost 20 years and is also the founding director and current clinical consultant for Baby Blues Connection, a mom-to-mom support organization. Please join me in welcoming Ms. Wendy Davis.
Get all my hair. Good morning. Can you hear me okay? Can you hear me now? Thank you so much, Sherry. I'm so happy to be here. I've unclicked, now I have unclicked the lavalier, so I'll just hold this here. Can you hear me where it is now? I'm thrilled to be in Colorado, and I'm so pleased with to tell you that the progress that you've made in this state to support maternal and child health, and specifically maternal mental health and the mental health of families is really key. You are pioneers. And what I want to tell you first, before anything else, is that you don't have to have, this is going to sound familiar, you don't have to have all the answers to be leading the way, to be strong. And that's why does that sound familiar? Because we tell that to parents all the time. So to be healthy and have a robust system of support for new parents, it doesn't mean that you need to know every single answer about how to support them yet. It means you can fill this room and have a waiting list and have a public health department that says this is a priority. So you understand what I'm saying. That's the same thing we want families to know, isn't it? You don't have to know what to do to know how to start, to know how to reach out, to know how to connect. And this makes you one of very few states in this still who has, I'm like totally dealing with this lavalier. I'm going to stuff it into my hands. It's always important to just say what is. How's that? So, my presentation is called Navigating the Way. So this is key, and you already get, the analogy is right here. You're not alone either. What does it take to know how to take care of families, take care of moms and dads who are pregnant, postpartum, and post-loss? And what does it take to find the resources no matter where you live, no matter what your interest is? So first I want to tell you a little bit about Postpartum Support International, of which I'm the executive director. I started as a volunteer for what we call PSI. And how many of you have heard about PSI? Wonderful. Yay, I get to introduce you. Postpartum Support International is a nonprofit that does three things. Well, we do many things, but three priorities. One, we have volunteers in every state and about 36 other countries who provide free telephone and email support, and in some cases support groups, to families in their area. We have wonderful Colorado volunteers. If you're our Colorado volunteers, would you mind just standing up a minute so everyone can see you and introduce you? Okay, we have, they're on their way. Jen is the first one here. And Jen's also going to be facilitating our lunchtime survivors panel. So we have an amazing core of volunteer support. These are wonderfully dedicated men and women, English and Spanish, and other languages too, who connect with local resources, offer that free social support through the internet, on the telephone, in groups. We have a chat with an expert phone forums. One every Wednesday for moms. Any mom you talk to can call and be on an expert facilitated phone call with other mothers and sometimes fathers, sometimes sisters and grandmothers. And that's every Wednesday for free, toll free. You can find that on our website. And once a month for dads. So the first Monday of every month, we have Chat with an Expert for fathers. And this is a wonderful resource when you have nothing else or you want to have something in between a session for somebody. Educational DVDs, 13-minute DVDs, one in English, one in Spanish. And we also have one just for fathers again. Well, it's not just for fathers, but it focuses on fathers. So there's examples of them on the materials table, but if you have questions or want to purchase one, let me know. And one of the exciting things is we've been able to work it out so that we can give permission. People can buy a contract to have reproduction rights, which is a great pun, I know. But reproduction rights to the DVD. So in some cases, for example, Kaiser in Northern California and the Mayo Clinic puts this on their their closed circuit TV. They show this to patients, 13 minutes, very hopeful message, a wonderful way to teach new practitioners or to show families, here's what perinatal, postpartum, and pregnancy mental health disorders look like. Here's hope, here's help, here's real people going through it. Our website is postpartum.net, and there's just a ton of resources on there. If you ever see anything that seems is incorrect, please let us know. And if you think things should be added, let us know. It's a really close-in grassroots organization that has a wide reach, but we are here for you, and we are here with you. So please communicate with us. And here's our warm line: 1-800-944-PPD 773. So you can call that every single day of every year in English and in Spanish. And then what happens is someone calls, and one of our volunteers assigned to that day calls you back, offers information, encouragement, reassurance, and resources. And I want to tell you that I believe this is why they invited us here, because we want you to know that none of you is alone in the work you do with families. And when you feel like, well, what can I possibly offer? I don't have even a therapist in this town. That's what we're talking about today. And one of the things you can offer is, here's a phone number that you probably didn't even know you had PSI volunteers in Colorado, and you do. And any of you, of course, we're always accepting new volunteers. And if you can provide bilingual support, it gives you free membership for a year, because it's very important to us to do that. So what I'm going to talk about first here is partnerships. First, I'm going to go back, because I told you PSI did 3 things. And I only told you one of them because I love our volunteers so much. So I start talking. It's like my kids. So I'm still talking about them. So we have volunteers, and that is why PSI started, is because they wanted to have social support around the world. We also train and educate professionals who treat and care for families, and find a way, third, to connect all of you together. So in a conference like this, all of you are you come to this as people in families. How many of you have children? How many of you are grandparents? Right. How many of you are children of mothers? Yeah. See what I'm saying? So let's talk about partnerships. I'm kind of keep moving out of the way of this microphone because I know you're videotaping. That's okay. In this presentation and in the one at 11:30, there are a lot of links to resources. If you go to the online site where they have they've done the most beautiful job of putting all these resources up, you'll see that if you just click on it, it's a live link, and it'll take you right there. If you miss that somehow, just email me and I'll send it to you. And all of this PowerPoint that you can look at the live site, you'll be able, because we live in the future and you can Google, just take the name of the resource and put it in and you'll get to the link. So this is from one of my favorite resources, MHA and SAMHSA together. They wrote it in 2008. It's still completely and wonderfully relevant. A great guide, maternal depression, making a difference through community action. So they're talking about partnerships, and I just want to really think about this. Partnerships with community leaders, the media, volunteers, civic associations, neighborhood health centers, women's centers. So you see how this is also why the Colorado Public Health knows why we need to expand and look at all these resources. This isn't part of the problem in perinatal mental health is that nobody knows really where it lands. Is it psychiatry? Is it early childhood? Is it obstetrics? Is it public health? Which is it? Yes. So yes. So that's why we want to make partnerships. Partnerships are the backbone of nearly every successful community program. Partnerships include a variety of arrangements and levels of engagement. So to produce results that one organization, community group, or coalition alone could not achieve. And one of the things that Colorado has done so beautifully is to pull together this coalition and then invite you. They're inviting you to join the stakeholders and the providers of all kinds together. Partners may serve as channels or go-betweens to help spread information. Yes, I really like graphics, and I like when they come out looking like teddy bears when you're talking about families. So we're all working together to support families, healthcare providers, childbirth professionals. So how many childbirth professionals are here? What if you call yourself like doula, or raise your hands high, midwife? Great. How many childbirth educators? Wonderful. Lactation consultants. It's usually all the same people keep raising their hands. How many labor and delivery nurses? And look around, because I think it's always great to see who else is here. How many pediatricians or pediatric nurses all together now? Great. Social workers, psychotherapists, psychologists, psychiatrists, researchers, volunteers, advocates. Sharon, you can go.
Midwives.
Midwives, I think, okay, midwives. And what have I missed? Because pastoral care, pastoral guidance.
We have
Postpartum nurses, because I said labor and delivery. How many postpartum nurses are here? Wonderful. I always miss someone.
We have
who did I miss?
public health nurses.
Oh, you're down. Everybody. Yeah. OBs? Any OBs here? Thank you for coming. And any other doctors, physicians? What did I miss?
Infant mental health.
Infant mental health specialist. Thank you.
Home visitation.
Say it again.
Home visitation.
Home visitors. Yes, thank you, home visitors. Thank you.
Can you move your microphone? When you turn your head, we can hear you, but otherwise we can't.
Thank you for telling me. We say speak up when you're down is our motto. We say speak up when you can't hear too. How's that? Is that better? Should I start over? So how do we integrate models of care? And I just want you to look at the different possibilities. We want to be communicating. I mean, now that you're back in the room, I need to thank you personally, Krista. You have just, I know she's going to leave again, just because I'm embarrassing you. You've done so much work to bring this community together with the support of your supporters, your supervisor, Mandy, and everybody else here. I just really want to thank you. I know what it takes to pull this off while you're doing your regular job, and you've done a fabulous job. This is how, but she's not alone either. See? You want to bring together medical professional school education, provider education, outreach and community networking, routine screening and assessment. We're not talking about mandates, we're just talking about what works in your setting. What can we all do together? Community resources and strengthening those bridges. So here's, in Oregon, I had the wonderful opportunity of chairing our maternal mental health work group that was passed through legislation in 2010. And one of the recommendations we came up with I'm using a couple of those recommendations because we really looked at 8 different areas, and one of them was partner roles and opportunities. So when you look at this, it is a way for you not just to look at the words and what we came up with, but think about it personally for yourself, professionally. Where do you fit in? Raising awareness and decreasing stigma. Advocating for improved services. These are things that partners, there's so many ways to help. Be the voice of families and frontline service providers in policy discussions. Engage medical community and social service providers in identifying and implementing change. Deliver family-centered, culturally competent clinical and support services, and provide training and consultation, education in all areas. I think what's really important to know is that, remember this, we're all links in the chain, right? We're all part of the safety net. So I know, as a person who went through perinatal mood disorder, that it wasn't one person who made the difference for me. It was all of the people, and in some ways it was the smaller interactions that kept me going. It was that one nurse. It was the way that my husband talked to me, because he was supported to talk to me that way. It was that one doctor who said something kind and understanding. So you don't have to have gone through a perinatal mood disorder to do a fabulous job with that. It helped with, like, you don't have to have a food allergy to have all the right things for lunch. It does help a little because you're sensitive to it. But what I want you to know is any one of you can be that person, that link in the chain that really turns the corner, that keeps that woman or that dad going one more day. And if you think that's dramatic, you have to understand and hear the voices, for example, of the panel we'll see at lunchtime, and just listen to the stories. It's not drama to say that every day a woman in a severe mental health crisis is at risk of hurting herself or hurting her family, but mostly herself, and that's what we're going to talk about. So then when we looked at an Oregon system and public health opportunities, we came up and it was so wonderful to be, we were embedded in the Department of Office Family Health in our Oregon Public Health Department. It was really, I feel so lucky to live in that state and like here to have our own Department of Health make this a priority. We looked at what can public health do, help identify the scope and impact of the problem, compile policy and best practice research. This is what Colorado has been doing, and that's why you're here together. And integrating, one of the hardest things is integrating mental health into all these other areas. Convene, seek funding, and identify and pursue opportunity to address maternal mental health across the state. So for just a second, I want to, you can sing along with me on this part. The history of the terminology, is this a little confusing? Because first we didn't talk about it at all. And all of a sudden then you start hearing postpartum depression, perinatal mood disorders. What do we call it? I'm saying don't worry about what you call it, just call it something. About 100 years ago, it was talked about more. This was part of medicine, and the reason for that is that medicine wasn't so categorized, it wasn't so specialized. It was more of a general practice. So as medicine got more specialized, things like mental health, and particularly mental health associated with childbearing, got lost. People stopped talking about it. That added to the taboo of talking about it. Really changed the face of care for women. So there were many decades just were lost. Then you start hearing postpartum depression, PPD, then perinatal depression, because people started pulling in the fact that mental health in pregnancy, the rates of depression in pregnancy are just as high in pregnancy as they are in postpartum. Did you know that? So perinatal depression is something you commonly see, especially in public health materials and information. The field of perinatal mental health pushes against that. Why? Anyone? What's missing in that phrase? perinatal depression. Anxiety, which is a key part of perinatal mental health. So we know clinically, people will say, well, it's okay to call it depression because we all know, meaning clinicians, that anxiety is a common part of depression. But the reason that the field of perinatal mental health has pushed on this is that moms don't know that. So they don't call us because they say, well, I'm not depressed. And they say really things that break your heart, like I love my baby, so I shouldn't call that mine. I'm not depressed, I just am crawling out of my skin, I can't sleep, I can't eat, but I'm not crying, so I shouldn't call that line. And anxiety is such a key factor, and if we don't somehow talk about all the different ways that these mental health and emotional challenges occur, people will talk themselves into the fact that they are to blame or that they shouldn't call for help. So we often call it perinatal, meaning pregnancy and postpartum, mood, because that includes bipolar mood disorders, and it includes anxiety, and it includes psychosis. And so we start saying that, but then I'm not going to go to a mom's group and say, I'm here to talk about perinatal mood and anxiety disorders. I said, I'm here to talk about the emotional side of being a mom, being a dad. It doesn't matter what you call it. Call it what works for the person you're working with. That's a great place to start. Why do we call it maternal mental health now? Well, many people, I agree with this, feel like that's a more positive term. And because when we went up for legislature in Oregon, they said perinatal what? Sounds like a body part. Oh, you're waving. Hi. So we call it maternal mental health. What is the prevalence? Oh my gosh, this is such a hot topic right now. It's really hard to figure out the prevalence, partly because it's called the smiling depression for a reason. You can't tell by looking. That's the state the motto of Wisconsin Perinatal Foundation. You can't tell by looking. A mom will put on a happy face. She'll go to her appointments, and so you can't really tell. Research has shown that when doctors say, I can pretty much tell who's depressed, that they can't. There's another reason for this. Even in research, how many of you have tried to look up, well, what are the stats anyway? Raise your hand. Like, how many of you have been confused by this? Is it 1 in 8? Is it 1 in 7? Is it 1 in 5? Is it 1 in 20? Why is it all over the place? I just want to take a minute to talk about that. One, when you're looking at prevalence and you do research, it depends what population you're studying. The rates of perinatal mood disorders are going to be different in different populations. That's what the stats are showing us. Also, where are you studying it? And are you looking in high stress areas? What's your method in a research study of asking about using a screening tool or a diagnostic tool of asking people, and who are your researchers? So if I am just a regular mom and I'm depressed and I'm anxious, and my researcher says, so have you been depressed or anxious? Have you any thoughts of hurting your child? No. What if that's a research? So we're trying to do our best, and I love the increased attention to this and the increased sensitivity on the part of researchers. As far as we can tell right now, the largest study done last year came up with, in the first 6 weeks, 1 in 7 women in a huge 10,000 women home visiting and clinic-supported study, 1 in 7 women were experiencing some kind of true postpartum depression or anxiety. In the whole year, when they looked at the whole year prevalence, it was 1 in 5. So these are from our last big meta-analysis, which a lot of people still use, including PSI. Prenatal and postpartum depression both coming in at about 1 in 8, 13.5. Do you realize how much that is? And that's true depression. That's not a bad mood. That's not somebody struggling. And again, 19.2% in the first year. PPD in teen moms. How many of you work with teen parents? You already know this, right? goes up to, when studied, from 26% to 60%, depending on the population studied. Moms of multiples, twins, triplets, and more. Am I still good at my sound? I'm trusting you to tell me. Yeah. At least 25%. And that's the rates of depression and anxiety. The prevalence of postpartum psychosis is 1 to 2 per 1,000. So it's much more rare. But when I first started doing trainings, I would say, and it's pretty rare, and then I started doing trainings for nurses, and nurses said, that's not a rare illness. Thank you nurses, I love nurses. 1 and 2 per 1,000, that's really common. So we have to know about these. Did you know this? The latest research in fathers using the same kinds of screening and diagnostic tools as 1 in 10 fathers has significant postpartum depression, and including postpartum anxiety that I'm going to talk about a little bit, and Dr. Rice is going to talk about, and we're going to hear, Dr. Horst, we're going to hear all about this for the rest of the day, that you have to know that when you're talking to families, we must also be asking fathers, how are you doing emotionally? Yes?
You said 1 and 2 per 1,000. Per 1,000 what?
Births. I'm sorry. 1 to 2 per 1,000 births has a risk of postpartum psychosis. So what are best practices? I love to refer to this resource here, the Registered Nurses Association of Ontario Toolkit, Implementation for Best Practices. Fabulous resource. So here's what they look at. Develop community network, assess and predict risk, accurately confirm, have effective prevention efforts, and implement effective treatment interventions. But here's the thing. I'm not just going to come and tell you the abstract. You hear that already. Before we can talk about best practices, we have to know how to decrease stigma and empower families. Why? Because of women like this. This is Jennifer Howtailing, who lived in Chicago, who looks in this picture, the picture of the supported and well off and doing pretty well new mama, right? That baby is young. And she's smiling, the smiling depression, but any of you as providers, you look at that face, is she smiling? Is she? She's terrified. Jennifer killed herself, threw herself in front of a train. And I don't mean to show you this family for help and provider accessibility. So how can we support and empower families? That's what the whole day is about. Think about where you fit. There's probably no other medical issue that I can think of, except perhaps for addiction and substance abuse, where someone comes in, needs your help, and is afraid to tell you what the symptoms are. Let's say you're a respiratory therapist and your patient comes in, but she doesn't want to tell you if she's coughing, sneezing, is it at night, is it in the morning, when did it start? How do you even begin to help her? And that's what it's like for families. She doesn't want to tell you what her scary thoughts are, how sad she is, that she doesn't feel love for the baby. Those are her symptoms, and she's not telling you. How do we reach out so she can? We want, the prenatal education is key. Normalizing. There's so many emotions through postpartum pregnancy. I want you to know that it's lots of families go through big emotions. If you need any help, if you have any questions, please call me. Informing about risk factors, asking and listening without judgment. Reassure and encourage, and referrals, resources, and follow-up. We can prevent a crisis. We know because risk factors are known, population is known, they're pregnant. Feasible to identify high-risk mothers. We have materials and some assessment tools. Screening is inexpensive. It's educational when you do it. So in the world of public health, if you're looking at primary prevention, and we have all of these markers, how good is that? Seriously, this is primary prevention. It's one of the few places we can make primary prevention. So can we prevent depression or anxiety 100% guarantee? No. What can we prevent? This is what I like to look at when I made this slide. We can prevent lack of information. We can prevent an escalation of distress, crisis. We can prevent discontinuity of care. We can prevent a relapse, working together, and recurrence of such an acute episode in the next pregnancy. Risk factor, prevention, and importance, all in one phrase. Across the world, suicide comes up as one of the 3 leading causes of maternal death. That's completely overwhelming if you feel like you're doing it alone, compelling, and it just tells the story of why we have to reach back before a crisis and why we have to reach the shame and the fear that families feel. So the PSI motto is you are not alone, you're not to blame, and with help you will be well. So if nothing else, that's what you want to remember when you're talking to families. You're not alone. This isn't your fault. Other moms and dads experience this. I just got to tell a dad this yesterday on the phone, and you could hear him pause, you know. Like I always tease my husband, I can tell when we're watching a movie or something, he's going to cry, he just gets really quiet, he breathes in. That's what happened on the phone. I said, you know, a lot of dads feel this, and the Academy of Pediatrics asked a bunch of dads, and they got, and 1 out of 10 dads were feeling just like this, just as depressed. And he went, then I waited till he breathed out, you know, because they feel really alone, and who are they calling? So use the word dad, father, partner. You're not to blame, you didn't cause this. This is not a reflection of you as a parent. When you can say to a parent, oh, this is not you as a mom, this is you depressed. As you treat your depression, as you feel better, you're gonna feel differently about being a mom. You're gonna feel differently about being a dad. With help, you will be well. All symptoms are treatable, no matter how severe. So I have a lot of kind of phrases that I use with parents, and the one that always seems to really have an impact on them is I say that a lot. All of these symptoms of perinatal mental health disorders, however I say it to the parent I'm working with, every symptom, no matter how severe, is treatable. Because they'll tell themselves, oh, well, I have a really severe case, so that's not so treatable. It's not true, right? So this is a good thing to remember. It's a sign of strength to reach out. They're not feeling that. They're feeling broken. They're feeling like, why is everybody else happy? Why do I have to reach out? We want parents, before it happens, to feel like it's cool to reach out. That's what we do. That's what a strong and healthy parent does. And is this a key phrase, all of you working with parents? It will get easier. How's this day going? It will get easier. So I want to put this slide in before I talk a little bit more about signs and symptoms. I'm just going to do an overview of the signs and symptoms because you're going to get a lot more depth through the rest of the day. But before we do this, I want you to just think about this. What does a baby know? How does a baby know it's cared for? How does a baby know it's loved? And I bring this up because whether you're a parent or a provider, you often hear people say, well, clearly she was depressed, so that's going to result in the baby being neglected, right? An opening for people to talk about their own, like this. There are just a couple ways that just examples. Becoming a parent can be a tough transition. Now, I like to say, when you are providing this care, you want the families to realize that you do this for all families. I ask people, did they screen you at the hospital? And often I'll get something like, oh, they did all right. And my husband said, why'd they pick us? So I think it's very good to say, we talk to all our families about emotions and mental health because it's such an important part of childbearing. How are you guys doing emotionally? If you do nothing else from this conference but add that word to your intake, to your questions, you'll change your practice. So if I say to you, how are you doing? You think about the weather, the baby, a bagel, a coffee, you know, the seat, the chair. What if I say to you, how are you doing emotionally? Do you go to a different place? That word alone will change your practice. Lots of women feel like being a new mom is harder than they expected. How's it going for you? You're not to blame for your depression. This is part of becoming a parent for many people. So those are some of the ways to start out. Do we know the risk factors? We do. Here's some that research has shown us, predictive risk factors. What I mean by this is that, right, they take the body of women who have a postpartum depression and anxiety and look back at their characteristics and what are the similarities. They're not causes. They're risk factors. Previous perinatal mood disorders, absolutely. Family history, personal history, or symptoms during pregnancy. History of mood disorders of any kind. Depression, anxiety, OCD, bipolar disorder, eating disorders. Significant reaction to hormonal changes, key risk factor, right? So puberty, PMS, birth control pills, Depo-Provera, pregnancy loss. If someone had a lot of emotional, mood disturbance or physical disturbance around hormonal changes, that's what's going on. She's at risk for having that around childbirth or loss. Also predictive, social factors, so inadequate social support, interpersonal violence. When you look at the PRAMS, Pregnancy Research Assessment Monitoring System, the PRAMS data is showing us more and more that the correlation of interpersonal violence and depression, not that we didn't know this intuitively, but that's really one of the highest markers. In Oregon it was, and I think I saw that came up here too. So we really must be looking at these together. And like we needed research for this, but we finally have it, thank goodness, to say poverty is a risk factor for depression and anxiety. And it has to be seen, and we have to address that vulnerability. High stress environments. Military families, the rates are up to 26 to 30% in military families. Teen parents, moms of multiples. Abuse, current or past abuse. And this is another question that, again, we are just, thank goodness we finally have the research to show us that this is something that absolutely not causes postpartum mental health disorders, but is a risk factor for developing them. And endocrine dysfunction, so history of thyroid imbalance, diabetes, and other endocrine disorders. So diabetes type 1, huge risk factor for postpartum mental health disorders. The rest of these, we don't have the stats yet. If any of you have big research or good research on it, write to me, because these are the ones where we want to say, well, we know these are risk factors, but I just want to be really clear that the first two slides were the ones that we have research on, and the rest are kind of consensus and definitely my opinion. So, childbearing and infant complications. But see, if having a cesarean birth were a true risk factor for postpartum depression, we would have much more. Because so it's a complication. It isn't the birth, the location, the method. What is it? It's the experience. You all know this, OB providers especially, nurses. It's the experience of that birth and the support through it. So complications in pregnancy, birth, or breastfeeding, age-related stresses. So think about this. You're kind of getting this. Adolescence or perimenopause. On either end, the combination of being in a hormonally unstable time of life, stress of being a young parent and an older parent, and the social, emotional, and physical stresses, that's what makes it a risk factor. Climate stressors. So in Oregon, in the Northwest, this is a huge deal. We have exactly the opposite that you do of sun to rain. Can you believe it? 300 days a year of sun precipitation in Oregon with no sun. So we use a lot of light therapy, and it's actually been well researched for perinatal depression to do a good job. So seasonal depression or seasonal mania in the spring. Perfectionism, if we had more research on this. If I only had to, oh wait, that's me being a perfectionist. But perfectionism and high expectations. We all know, how many of you know this? The people that you work with, those are the moms we really worry about. Because, why is that? What happens is that you might think of women who are more dependent in style would have higher rates of depression. No. It's because when women are dependent in style and things are difficult, they call someone, they say, this is really kicking my butt. I need some help, where's my spaghetti? This baby's driving me crazy. A perfectionist, when she's struggling, when he's struggling, they retreat, they try harder, they shame themselves, they don't reach out. And what happens to depression, anxiety, mania, the prodromal issues that lead to psychosis, what happens when you don't reach out? You get worse. And what happens when you berate yourself? So that's why perfectionism, we have to address that. On here, and you'll have it in your handouts, and you can write to me if you want more. This is a risk factor checklist that I put together because the state of Oregon wanted one. And I just took the risk factors and turned it into an interactive set of boxes. So I had somebody tell me at a conference I did recently, she said, you know, I've been a doula, childbirth educator for years, and I've looked at that screening, the Edinburgh and all that, and I never come up, but I know that I suffered postpartum. She said, this list, I checked every one. So I thought that was interesting because I just took it from risk factors. It's hard for me to ask for help. I've had trouble with hormones and moods, especially before my period. I have this translated to Spanish too, if you want. I was depressed or anxious after my last baby or during my pregnancy. So you see how they're the risk factors that we just went over. Depressed or anxious in the past. My mother, sister, or aunt was depressed after her baby was born. Sometimes it's hard to slow down. I don't get sleep, have lots of ideas, and feel very restless. What's that risk factor about? Right. Bipolar mood disorder. My family is far away. I don't have friends I can count on nearby. I don't have money, food, or housing I need. Those are all evidence-based. So then if you check it's not a test, it's not a diagnosis. If you check 3 or more, you are more likely to have depression or anxiety during pregnancy or postpartum. Reach out for help to reduce your risk. And then on the handout we have Postpartum Support International, or if it's local, we have the local support. So they know where to reach out. Don't forget the partners. Dads and significant others also experience stress, anxiety, and depression. I love that picture of the dad trying so hard. He needs to know it's not his fault. You recognize the 2 women. Grey's Anatomy. I hope they're okay. This is the last picture. Grandmothers. So, many shades of blue. Perinatal mood disorder can begin anytime during or after pregnancy or after loss. When we did legislation in Oregon, we included post-loss, which I was really proud of because I think if we're not also addressing the mental health that families experience after loss, then who will? We have to address that. It might merge with the baby blues. Did you know this? Or start, you have to know this, 3 months, 4 months, 7 months later. It doesn't always start right after birth. Baby blues can be actually totally a normal baby blues, and she gets better and then comes out with a full-blown mood disorder at 4 months or at 5 weeks. Who is she seeing then? Pediatricians, yes. Onset any time in the first year postpartum. Common triggers for late onset, hormonal triggers, rapid weaning, plus hormonal sensitivity can begin the whole postpartum mood disorder. Hormonal birth control, or increased family stress. For example, she returns to work, her partner returns to work, mom goes home after being here for an extended period of time, or mom comes, mother-in-law comes. It can be good or bad, right? We can't make assumptions. illness or hospitalization, and loss and grief. So the types, which as I said, I'm just going to look at real quickly with you, but I wanted to put them all on one page. Prenatal, complicated baby blues, if there's other issues going on, especially major postpartum depression, postpartum anxiety or panic, postpartum OCD, bipolar mood disorders, and postpartum psychosis. You might also have grief, post-traumatic stress, acute stress, postpartum exhaustion, or endocrine disorders. So when we look at cause, everyone wants to look at cause, you have to just remember it all works together. Physical, the genetic predisposition and sensitivity to hormonal change, right? Psychosocial, inadequate support, perfectionism, and superwoman. We expect families to do this alone. Nowhere else in nature, in no traditional society, would you ever see a mama alone with her baby, unless she's shunned or there's some reason that she's been ostracized. So we think we should have our own places and do our own thing and be perfect mommies and never be unhappy. And that's part of what increases the cause of depression and anxiety. And then there are concurrent stressors, as well as the physical and the social. Sleep disruption, poor nutrition, and all the stuff we're going to talk about today. Cultural stress and barriers. I think it's critically important to rule out other causes, so you want to look at how many of you already know about this. Thyroid imbalance. It's really important. Low thyroid or high thyroid, so common during pregnancy and postpartum, even for women who've never had that, and masquerades as low thyroid, looks like depression. This is the shortest piece on this I could ever give. Low thyroid looks like depression, high thyroid looks like anxiety. If there are a lot of physical symptoms going along with that, please find a way for her to have a thyroid panel and check that all out. And write to me about any of this, but about that if you have more questions or need more information. Anemia, exhaustion plus restlessness. So that's a very important thing to check out. What trauma is happening now and what has happened in her life, and side effects of other medicines, alcohol and drug use. So ask always, can you tell me what other supplements or medicines are you using? Be very attentive to if she's using medicines to increase milk supply. Reglan, which is commonly prescribed to moms. It should be prescribed for about 2 weeks at the most to increase milk supply. In moms who are sensitive, I see some knowing looks over here. Moms who are sensitive can have full-blown anxiety on Reglan. And sometimes it's prescribed for months. Because I really want to increase my milk supply. No. So really find out what else she's taking. Culturally, always know, we don't know anything. That's my cultural sensitivity 101. I don't know anything until you tell me. And even if I think I read up and I understand this culture, that religion, I don't know until I ask, what's it like for you and your family? What are the lessons being passed down to you? Unexpected symptoms. I thought I could just do a little bit of this because I think this is kind of the key part that we don't expect to see the obsessive thoughts and fears I'm going to talk about in the next slide. Agitation, anxiety. So if you think about postpartum depressed, you have a common picture, an image of that. You must include in that picture anxiety, agitation, restlessness, perfect moms, perfect houses, trying too hard. When thank goodness, I don't have PTSD over my postpartum experience anymore, but I did for several years. And you want to know something, I still search for, I wish there were a word in English for the emotion that grabbed me every year at that time. And I don't. The emotion wasn't sadness. It was trying too hard. Is there a word for that? It's that sadness and fear, and I was trying so hard every day with myself, my baby, my husband, and there's no amount of trying that cures depression, see? So that's what you have to understand. Women are trying so hard and they need you to say, oh, honey, you are working so hard. I'm here to help you. Insomnia, mania, protectiveness and hypervigilance, and drug and alcohol dependence. So, depression mood swings, fatigue, the sense of lethargy. And really what moms tell us is, I am overwhelmed. Anger is a huge part of depression. Anxiety, if you want to really assess really quickly, how is mom doing? Ask her, how is she sleeping? Ask dad, how are you sleeping? When we meet new parents, what do we say? How's the baby? Is baby sleeping? Ask her. The key indicators are going to be that sleep, appetite, mood. So with anxiety, she might be having panic attacks, insomnia, low appetite, fears of losing control, physical symptoms, all the physical stuff because it's the high adrenaline. So whether you are a physician or a teacher, a home visitor, you can address these things. It doesn't have to all be medical. And it doesn't have to all be social support, and it doesn't all have to be nutritional. It's all of those things working together. And I'm going to talk about at the lunch panel how we keep from being overwhelmed with that. I'm going to move a little quickly for the sake of time because we're going to stay on time. Trauma. Please know trauma, as Cheryl Beck says, a great nurse researcher, trauma is in the eye of the beholder. You don't know from the outside if she has trauma going on or if she had a traumatic birth. But we have to understand that this is part of perinatal mental health. Perinatal obsessive compulsive disorder. How many of you have heard of this before? Okay, this is so important for you to know about. OCD is an anxiety disorder, okay? It's not a thought disorder. What do I mean by that? The symptom, anytime someone has OCD, you have an intrusive thought. You know it's not rational. It just keeps coming. You can't seem to shake it. This is what happens with perinatal OCD as well. Intrusive thoughts, fears, or images. Tremendous guilt and shame about those thoughts. Horrified, they're hypervigilant, and moms or dads, and dads will get this too, engage in behaviors to avoid harm, to protect the baby. What do we need to do? Educate mom that thought does not equal action. Because here's what happens. This is a really common symptom. How often is it reported? Do you think someone is going to come into your office if she's never met you before and say, I walked through my kitchen last night and I wondered what would happen if I stabbed the baby. And then I ran out of the kitchen and burst into tears and knocked myself in the bathroom. It's an anxiety thought. And how do we know it's anxiety? Because of her reaction to it. So we will be hearing about this through the rest of the day, but I want you to know how important it is to understand the difference between anxiety, the intrusive and scary images of anxiety, and the intrusive images and fantasies of psychosis. In psychosis, the thoughts make sense to the woman in her psychotic state. Yes?
I have a question.
Yes.
So the obsessive disorder for prenatal, is that typically if you're already diagnosed?
Thank you for asking. Yes, the obsessive disorder with prenatal, is that typically if you're already diagnosed? No. If you're already diagnosed with OCD, yes, you are at higher risk of having a return or increase of symptoms postpartum, but this is part of what's so scary is many moms who have postpartum intrusive thoughts and anxiety have never had that before. So how we address it is to say things like this. Again, like I said before, if you say to a mom, are you having any scary thoughts or thoughts of harm to your child? No. That's what she'll say, no. But I say, lots of moms tell me that they have scary thoughts they can't seem to shake and they keep returning. Has that happened to you? Now, if she hasn't had them, she'll say, like, I'm really tired, or if she has, you see her relief. Yes. Can I talk about that? And we have to so want to reach into family and say, oh, I know the symptom. This is a sign. This is a kind of anxiety. We will help you reduce that symptom. If you do an assessment and it's not danger of abuse, she's abhorred by these thoughts she had. If you ask her, have you ever been close to acting on these thoughts? No, oh my God, I hid the knives. I don't give the baby a bath. You can talk with her and educate her about what we're worried about is not that she will harm her child. What are we worried about? That she will harm herself because she's a high-achieving, maternal, protective mother with anxiety. I hope you all hear that because I'm I'm going to take the time, even though I have 1 minute to say this. They've done research that shows that brain mapping, people who have this symptom, the part of their brain that lights up is a part that's responsible for protective instinct, not aggression. That's halfway through the session with the mom, the first time I see her, that she's adding this. You just go, oh my gosh, instead of being a monster, I'm uber mom. I say, if you were a cave woman, you'd be the head of the pack. You'd be watching for tigers and bears and tsunamis and havens. You're looking at microwaves and knives and baths and abuse because that's what's in our culture. It's really an important thing for us to know. Bipolar disorders, 60% of bipolar women present as depressed. Why is this important to us? Because if we don't do a history and find out about the bipolar cycles, but only treat them for depression, we can peak a manic episode. Postpartum psychosis, again, 1 to 2 per thousand births. Early onset, peaks in the first 2 weeks. So women who have OCD or depression and are afraid, like, what if I snap and become psychotic? It doesn't happen that way. It doesn't. This is a separate illness, an important illness, and moms and families that we're learning about. Before psychosis may be overexcited, hypomanic, building up, might have delusions that the baby's possessed or hallucinations. Andrea Yates, how do we reach out and help these families before there's a tragedy? So I just want to remind you the differences between postpartum OCD and psychosis. They're just really, it's like you could have a cold and it might turn into bronchitis or pneumonia if you don't take care of yourself. There are ways to prevent that. But a cold won't turn into the measles. The measles are really important to prevent as well. It's really important to know we don't want to scare people who have anxiety and depression, because if they're scared by the messages we give that, oh, but you could get psychosis if it gets really bad, they become more suicidal because they're afraid of what will happen. We also don't want to scare people who actually are at risk of psychosis or have had it and make them feel like, well, they're really a separate category. I'm going to continue when we have our lunch session, but I want you to know there are resources for parents. We have posters. I have some here. It's kind of first come, first serve. We have mom, dad, it's Spanish and English. We have the DVD, like I said, the HRSA brochures I think are wonderful. Spanish and English. There's a link where you can get them. Internet resources, these are all well vetted, moms, dads, and professionals. MedEd PPD is one of my favorite ones for both parents and for professionals. Please look at that one, postpartum about that, of course. If you want to know about medications in pregnancy or breastfeeding, see, I feel like this is the place where this keeps providers from helping, right? Well, can you even take medication? These are really good resources. Websites, telephone numbers you can call, families can call, their pediatrician can call, or look at the website. And these are the places that keep track of the evidence about risk of medication or lack of risk during pregnancy or breastfeeding. Isn't that good to have? PTSD websites. And then provider tools. The last thing I want to talk about in this talk is this. When you are a provider for families, guaranteed you will feel overwhelmed. Whether you're a volunteer, a doctor, a home visitor, a teacher, a nurse, because it can be overwhelming. Look at what your stress is and your triggers. This is my anti-stress question, and I ask it about once a day. When you're involved with a family, a mom, a dad, instead of saying, oh my gosh, what do they need? It's so much. Ask yourself this. What is my role in what they need? And just be that best person, do your best practice. And part of your practice is reaching out. Where do you get support, whether it's in your own supervision, in your own family, or call us, me, PSI. That is what we're here for. We're here to support the providers and the families. If you're looking at community development, we'll go over some of these later. But also for education, sometimes support comes through
are some places you could get more training. So this is all on your handout. The PSI, we have a 2-day certificate training course, which is one we call get a certificate of course completion, and we bring it to we are brought to different states around the country, and I got to go to France and do it last year, which is amazing. We have online webinar now, 2020 Mom Project and PSI together has a 6-class course where you get a certificate of course completion. Kara Kynan has professional clinical trainings in Pennsylvania. Again, online curriculums, there are really only 2 that are specialized and confirmed. Med-Ed PPD and STEP PPD, which is designed for providers. Our conference, PSI conference, is in Chapel Hill, North Carolina. It'll be a little warmer than today. Chapel Hill in June. The PSI pre-conference on the 18th and 19th, and the main conference on the 20th and 21st, and next year in Detroit. But we love our conferences. How many of you have ever been to a PSI conference? And we just really invite you and hope that you can come. Again, these, if you click on them in the handouts, they'll go right to the URL, or you can just put them in, like I said, into Google. Thank you so much. We're going to have a wonderful day, a full day, with all kinds of new information and new support. And another PSI volunteer in the room. So thank you so much.